Good afternoon, hello, and welcome to day 3 of Clinical Audit Awareness Week 25. So our series of daily lunch and learns with today's topic on healthcare inequalities and how we can actually effectively utilise clinical audit to address that unwarranted variation in care. So my name's Vicky Patel, Chair of NQICAN and Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust and your chair for today's event. So it is being recorded. It would be lovely to see your cameras on, but obviously if you don't want to be recorded, feel free to turn them off. And you'll also note that your mics are being muted. So there will be the opportunity to ask questions, and at that point we'll unmute you to allow you to raise your question to the speakers. Q&A functions live, so please do also utilise this to post a question or add your comments relevant to today's lunch and learn. The chat function is there, but we're opting not to use that today and have the focus on using the Q&A function, and we'll leave the chat there just in case we have any technical issues. So next slide then, please. So as we're moving through the week with our lunch and learns, 12:30 till 1:45 every day, then you can register via the links on the NQICAN Future NHS Workspace or the HQIP web pages. So do have a look at events that are being held on Thursday and Friday and consider joining us. Today's topic on healthcare inequalities, as we've already said, and it remains an important domain of quality alongside the other effectiveness, patient-centred,
They're at the door. I need to get them away.
Equity and efficiency. Our Clinical Audit Awareness Week 25 topics, they reflect all of these domains, and we do hope to see you join us as the events as we go through this week. So next slide then, please. And I'll take you through today's agenda. Fantastic. So we'll just begin with that introduction and that recap and touching on last year's takeaways to set where your thoughts are as we start to focus on today's topic on healthcare inequalities. We're going to hear from our key speaker on key information and points that we need to be aware of and actually consider back in our own organisations and systems. In particular, information that we must take into account when we're planning and delivering services, but also when we're measuring that impact and looking to reshape health and care so that we're addressing health inequalities and, of course, improving those health outcomes for all. You'll have the opportunity to ask questions to our key speaker and then obviously to our winner and towards the end of the event. Really excited to say that we're going to announce the Healthcare Inequalities Clinical Audit Hero Award, and we're actually going to hear them present their winning entry as well. Before we close, we'll just ask you to participate in an interactive valuation, and then we're going to challenge you, as always, to take away a key challenge back to your own organisation and system based on what was shared with you today. So if we just move on to the next slide then, please. We're going to touch on last year we tasked you with being bold and ambitious, and we still want you to do that. However, this year we want you now to be adding in that value and impact. So just making those informed decisions that you know are going to add value and they're going to add impact. So each day this week we've highlighted the recent NHS review that was published last year and key points that are aligned to each day's topic, and in particular for clinical audit and wider QI. So what does that review now mean for us back in our organisations across our systems with our local projects and our national projects as well? So Lord, as he mentioned, reframing clinical audit as that strategic tool. So I think now we've got that accountability and responsibility to make sure that happens. So he touched on re-establishing quality as one of the organising principles of the NHS. He's tasked us with aligning our audit priorities with national goals, such as reducing health inequalities, improving access and actually boosting our productivity. Clinical audit teams do need to position themselves as strategic partners within the quality improvement approach that our organisations and systems are taking as well. And obviously we need to now increase our efforts in terms of targeting that unwarranted variation. So that local focus maybe on certain specialties or maybe within region between areas and organisations where we're seeing that greatest variation from evidence-based standards. And then how we're using our audit cycles now to drive that standardisation of care and reduce those inequities in care delivery. And we almost need to be those innovation leaders. So our audit team should start to embrace that continuous or rapid cycle improvement alongside looking at that cross-sector partnership work in that collaboration with social care, public health and community services. And then as always, we push for that triangulation of our audit data with everything else that we know. So the other thing that the review touched on was the fact that inequalities are actually getting deeper, and we know that our national clinical audits are highlighting this, and I know that Danny's going to touch on that in a little bit more detail later. But linking in now in terms of some of our topics on our other days, so thinking about patient safety and efficiencies. In terms of healthcare inequalities, those delayed actions mean preventable harm. That late diagnosis, as people are not either accessing our services or they've got unequal access to treatment based upon postcode, that could result in increased mortality and morbidity, and of course those longer term resources to support that based on those avoidable complications. And then just linking in with the patient and public involvement that we focused on yesterday and trying to amplify that patient voice, Darcy also stressed that patient empowerment and engagement. So for us as clinical audit teams or clinicians undertaking those local projects or participating in the national ones, it's really starting to think about co-designing the projects with our patients and communities, triangulating it with patient-reported experience and outcome measures, and then making sure that our findings are accessible and meaningful to the public. So we've got to act now on healthcare inequalities using clinical audit, because that evidence shows that disparities in healthcare access, diagnosis and treatment are persistent, measurable and worsening, and clinical audit is one of the most effective tools that we have to address them. So going back to that then, it's stressing that continued, be bold and ambitious message, but now adding in that value and impact. So next slide, please. And it's that opportunity to just spend a few minutes here just reflecting on the takeaways from last year's Lunch and Learn on health inequalities. And whilst you just have a look at some of the feedback that you provided to us, we also set you that challenge to take away, to focus on improving those incomplete data sets, starting to look at your ethnicity data and your health population data, aligning your clinical audit improvement plans with your local health inequality improvement plans, and triangulation of experience and health outcomes, whilst also addressing access, having those open and transparent conversations, and now starting to think about that system working. So they're all still relevant takeaways for today, but we're just going to see how far we can stretch you based on the information our speakers are going to share with us today. So if we just move on to the next slide then, and just focusing back again on the NHS review, then we know that life expectancy is rising, but people are living longer in poor health, and that's going to put increased pressure on health and care. We know that we've got social factors such as the poor housing, the low income and employment, which will impact on that rise in chronic illness and mental health issues. And we also know that some of our communities are still facing higher rates of those preventable diseases and lower access to care. So all of this has an impact on these four areas that we've highlighted here: the physical health outcomes, the mental health outcomes, that child and adolescent health, and that older adult health. And the focus on utilising clinical audit to address the health inequalities and improve health outcomes for all, that equity is really, really important, and we need to be focusing on how we can actually take this to the next level now as a result of everything that we're covering this week. So next slide then, please. And we've just popped up a little bit of an example, really. So we often get feedback from these events saying it's fantastic to receive this information, but we need a few more examples of how we can take that away and apply that locally. So this is just one example here. There's a lot of information on the slide. It's for you to take away and consider when you're starting to plan your local audits as well. This is just one example. So here, looking to improve that blood pressure control in socioeconomically disadvantaged populations. And this is through primary care and community services. So it's a local audit with a focus on that population. It's a collaborative approach with our system partners and a focus on that preventative measure that fits with our shift in our focus going forward. So we're aiming to improve the self-management of hypertension by improving access to services and information. We've got our criteria here with that focus for meeting that aim that gets broken down into standards. We've got suggestions here for that wider data collection in order to address those inequalities. Some suggestions here for improvements and how we'd expect that to impact on our outcomes. So actually, when we do our project planning, we always ask everybody, well, what are you expecting to change? What are you expecting to get out of the project? And then we reflect back to make sure that we've actually collected the information we need to be able to achieve that. So if we just move to the last slide then before we hand over to Danny, then it's then thinking about how you're going to measure that impact. So again, this is information for you to take away. You really must start to think about, well, actually, it's fantastic we've got these clinical audits in practice, but actually, what metrics are we also going to use to show that they've added value and they've added that impact? And two, maybe just to pull out here quickly, is access and equity around those appointment attendance rates, percentage of patients receiving care within that targeted timeline. Over time, you want to see that gap become less between all patients, regardless of that ethnicity, postcode and more. We've got a lot of projects in our organisations, and I think we now need our exec buy-in to focus on less priorities, and actually we do them well. High quality improvement projects that add value and add impact. So just going to move on to the next slide then, please. And really pleased to welcome back Danny Keenan, now Medical Director at HQIP, who's here with us all today to celebrate how audit can drive evidence-based improvements to address healthcare inequalities. And we're sharing information with you all that you'll need to take back and take forward within your clinical audit and wider QI work streams. So I'll hand over to you, Danny.
Thanks very much, Vicky. You've already given a huge amount of information, which is incredibly helpful. So thanks for that. I'm sure colleagues will be very grateful to receive all of those bits of information. These weeks are wonderful for us in HQIP. It gives us a chance to actually meet you, who are sitting at the front line, bearing the brunt of all of this work. And it's just firstly to say thanks for all the incredible work you're doing. The audits would not take place if they weren't for yourselves, making sure that they get completed, sent in on time, and all the other many thousands of things you do. So thanks very much, and it's great to meet with you. And we hope to get some questions at the end of this. If you just head on to the next slide. By the way, I'm Danny Keenan, Medical Director at the HQIP, seconded from Manchester. So what I wanted to do was give you an update from where we are and to do with looking at health inequalities from the obviously the multiple ways of looking at this, but we obviously do national audits and we advise on local audits. So it's essentially looking at it from that perspective. And to get the update is just to remind you about the wonderful survey that was done last year by our two colleagues, Alice Bradley and Alice Conway, who surveyed the audit providers. The reason we did this survey was because the audits were essentially they were picking up inequalities, but not incredibly well. So we wanted to explore with colleagues why was that. So I'm going to give you an update on that. Not really an update, but more to mention CAAW 20+5. All of us are intimately involved in that. Charlotte last year did a huge, wonderful presentation. And indeed, you had a presentation on Monday. Anybody who hasn't seen the presentation on Monday, which was to do with CAAW 20+5 with a safety perspective, please, you'll be able to get those slides from our website. A really, really interesting presentation. And I'd like you to go and listen to the blog video podcast that I did with Aoife Malloy. To be frank, it was all Aoife's because I was questioning her, and Aoife is giving in this a great perspective from the CAAW 20+5 as to actions. Because in some respects, we've done a lot of the what's it all about. We're now thinking about the actions. Please go to that because there are lots and lots of ideas on that podcast that will set you thinking and give you ideas to move forward. Can I have the next slide, please? Thanks. So this is back at the survey that was done last year, and just to give you that update. So the key findings are in these next two slides, and firstly, the routine data sets, the problems to do with ethnicity. Obviously, if you don't get ethnicity coded, then when you start doing algorithms and breaking down and saying who does what outcomes are what, then it's not very secure. And incomplete data was a big problem. And why was that a problem? And it was to do with categorizing and coding. And we found lots of things like individual patients being coded on different times and different admissions in different ways. You know, obviously there needs to be a very standardized way of doing this. That came through on the routine data set. But as you will know, because you do a lot of this collecting of data, there are also bespoke data sets, and it is time consuming and you know, teasing out what ethnicity to put it in a form, even electronically, because you'll know this, there's 16 codes and picking down. And unfortunately, the commonest code was, not the commonest, but a common code was 16, which is unknown. And then there are things to do with consent and like, so essentially, these were the problems, the big problems. And there are solutions, but these solutions may be a bit longer than one would think, thinking about the whole government's move from analog to digital. This is in there. It's not like this is not going to be addressed. It is being addressed, but it might not be addressed in the immediate time period that we're thinking about. And I'm going to come back to that later on in these slides. If I can have the next slide, just these are the other things that came out from the survey that the two Alice colleagues did. Population data wasn't particularly secure because one needs to be reflecting back on population data when we're trying to make comparisons and draw conclusions. Cost is an interesting one. Obviously, the audits are very, very tightly controlled in terms of finances, and analytic colleagues cost money, and they are doing whatever it is they're meant to be doing. We have addressed that by virtue of as the contracts for the different audits are being tendered, and truthfully, most of them will have been retendered in last year and the next year, including ethnicity and deprivation as core parts of the work, so that we will be seeing more detailed work coming out from the audits. Small numbers is always a problem, and that's something that we are working with the audit providers. But you can imagine if the small problem, and this is one of the small problems, that we don't have enough of such and such a group, therefore we will group them all together, and instead of having 16 codes, we're down to 3 or 4. Well, we've lost it then, because what we're actually trying to find is the differences in outcomes and the like, depending on different ethnicity. And if we've lost the ethnicity, then we've lost it. So we are dealing with that. So thanks. If we go on to the next slide. By the way, we are going to have a question and answer session at the end of this, so please store up any questions, and we'll knock them about when we get finished. So then the next few slides are really to do with the Embrace. Embrace has pulled ethnicity and deprivation really to the fore, and I think basically, if we can't get things right for pregnant women and for babies, neonates, and the like, if we can't get in a society like ours, if we can't get it right for them, then we have got a problem, and then we will see obviously problems in other areas, which I'll come into. So anyway, I'm going to spend a little time on the next few slides on Embrace and to do with maternity and neonates. Can I have the next slide? Thanks. Right, so this is an overview slide. And I just wanted to, we're not going to go through all of this, but I just wanted to pull out a few areas. And on the right, I don't have a pointer, but on the right-hand side, you can see where it came to became stark, and that was to do with COVID. COVID brought the big lens. It's the third one down on the right. The big lens hit in on deaths during COVID. And I think most of us were taken aback by this, that essentially there was a twice death rate for Black and minority ethnic groups. I think that's a statistic, that's a fact, and that is that brought us all to a halt. I thought, wow, what is going on here? So that was the start of us like getting real about what's going on with ethnicity deprivation in terms of outcomes to do with the disease. And like up at the top left, many of us know this one, but one has to be repeated. Times for death for Black women in pregnancy. Wow, that is a big statistic. ×4, and then obviously lesser, but still Asian ladies also have a higher death rate. And as we go through these, lower down, actually at the very bottom, 24% all deaths, cardiovascular disease, higher in Black and minority ethnic groups. 24% of death rate higher. That's a big number. So there's something in there that draws attention to it. And similarly at the top right, diabetes, exactly the same. Bigger problem there, ×2 to 4. A big problem, and it goes on and on. The next one down is prostate cancer, bad outcomes ×3 for Afro-Caribbean men, and more likely to catch it ×3. So it goes on. The life expectancy, the very bottom, 10, the one with 10 years on it. So that is Bangladeshi men. Disability-free life expectancy is 10 years lower. Like we're not talking about these men in Bangladesh. We're talking about these men in the British Isles. That's a very stark thing. So these started off with COVID, bringing our attention to focus on this problem, and here we are. We're finding it everywhere, and that's going to be the theme here. In the next slide, please. About finding it everywhere. This also comes from Embrace, and this isn't death. This is just how we approach pregnant women from ethnic groups. So we've looked at the starkness, but here is I suppose this is a more subtle understanding of what's going on here. And this was Embrace looking at interpreters, and they looked at 5, 8, 9 separate contacts, and it was pretty bad. A professional interpreter in 27% only of contacts. Next one down, 50% of contacts lacked any documented interpreting provision. That basically means these ladies come up and 50-50, they had no clue what was being said to them or what was going on. I think that's a pretty stark thing. Then we get on down to when these ladies come in interpartum care, only 31% had any documented professional interpreter. So that basically means that 70% of these ladies come in to deliver a child and hadn't a clue what anyone was saying to them. That's not good. That's not good at all in a caring society, as we're supposed to be a part of. And you can see the very last thing is no woman received professional interpreting contact for every contact, which is what's meant to be. So like that's a wake-up call. And this isn't critical of maternity services, because I bet these numbers replicate themselves across the board. The next slide, please. Okay, so I find just to bring the Embrace thing together, because obviously these did need a lot of interpreting and recommendations. So accurately recording, that goes without saying. We don't have the information, we don't know, and it's not just, you know, we've been in the last few slides saying Black and ethnic minorities. Like there are loads of different languages spoken, there's different customs. We're meant to be a caring society. We're meant to be accommodating to these. Then we got this on the second recommendation down, recording of language needs so that you can get the first base on this, support and help to overcome barriers. And that this is support and help for the staff. You have to understand it's not very much fun going in to deliver a baby and you don't understand one word of what's going on around you. And then specifications for risk factors, which are obviously different and very real, given that we are seeing differences in mortality. And as we'll see in the next slide, differences in outcomes for babies, and so on and so forth. But the last one's important. We need training and support for those dealing with women. And my belief is that what we've found out is that this is across the board. This just brought the lenses on this, but why would it be any different for general surgery, cardiovascular disease, interventions, whatever, you name it, it'll be the same. The next slide, please. Thanks. So the last two slides are to do with the infants. When I look at this slide, it takes your breath away. It really does. So the difference between left and right is a 9-year gap. So even if we leave the thing that we were bad in 2013, the truth is we're no better in 2022. So if you are a pregnant lady, your stillbirth rate in the black group is twice that of the population. That is very stark. Twice the Asian group, 1.4. And if you just go over to the next slide, thanks, we look at neonatal mortality. And again, we are meant to be a caring society, and that means everybody's equal, and we are trying to apportion resources to get the best outcomes we can for all concerned, including what we're seeing here, neonates. So you can see here again, neonatal mortality rates, 1.5 up in black babies as opposed to the across the population. These are horrible numbers, really. You know, this is something we have to work at, and it really, truthfully, hasn't changed in the last decade. So this is a call to action. Go ahead, hit the next slide, please. Okay, so the lens came in there on neonatal babies, maternity, but we're not going to dismiss that by saying, well, that's all that stuff, that we're all okay. We're not all okay elsewhere. So I just went through some of the audits, and in some respects, the audits are doing workarounds to make sure that they do get information out, even though it's not the top quality information because of coding and the like, but they are getting messages out. And I just picked some of these messages. So CVD, prevent cardiovascular disease. Asian ethnicity gives you a higher mortality with a heart attack across the board, more likely to die if you're Asian than the rest of the population. Black ethnicity, higher mortality with stroke. And then together, things like atrial fibrillation. Atrial fibrillation is responsible for a lot of morbidity in men and indeed in the population. And again, higher incidence in atrial fibrillation. These are things that we in a caring society need to be thinking about, working on, and getting strategies, and possibly bespoke approaches for these populations. So maybe if it works in one group, it's not working in the other group. So more bespoke approaches. And I think that's going to be an important for solutions in this world. I've already mentioned prostate cancer. That's a very stark number. This business about the higher mortality, very stark. And then maternity we already mentioned. But I just the last line. Just want to bring the last line forward. So it's not just death that's higher, but look at the virtually all other complications in pregnancy, higher preeclampsia, postpartum hemorrhage, diabetes, all higher. So in some respects, you might say it's not one thing or the other thing. It's a whole system approach that needs to be thought about in terms of the approach to tackle the poor outcomes for these groups. That what we're doing for the population needs to be more bespoke for the other population. Next slide, please. Okay, and just carrying on in that theme of across the board, pediatric intensive care, deprivation. I haven't really mentioned deprivation much, but deprivation and ethnicity hit different buttons, but frequently hit the same button. And that's a double whammy, so to speak. In terms of pediatric intensive care, all ethnic groups and deprivation have higher admissions. That's again a very stark number, isn't it? When you look at why is that, and what are we society, probably much wider than we in healthcare, but we in society thinking and doing about tackling these root causes that lead to these problems. Epilepsy deprivation is interesting. Deprivation came out very high in having groups suffering from epilepsy in the deprived population. And again, you can imagine the delivery of epilepsy services being a bit more bespoke and therefore more difficult. You can imagine in the inner cities where we have deprived groups in large numbers, getting an epilepsy service focused right in there is, I suspect, very difficult. The next one down I thought was a really interesting one. Okay, so we got national inflammatory arthritis. This looks at your first presentation on inflammatory arthritis. You would have thought something like that maybe there wouldn't have been an ethnic thing, but here we are, all ethnic groups, low rates of disease remission at 3 months. So this just goes to this theme that it's across the board. It's not one condition or another. That essentially that the ethnicity and deprivation essentially leads to poor outcomes, no matter what way you're presenting or what disease it is. Type 1 diabetes, I'll just finish off on this one. Higher levels of HbA1c in these groups, and also the second one is, now this is to do with us as clinicians. Why is it that ethnic groups and those with deprivation get less kind of, so to speak, state-of-the-art treatments or interventional treatments like insulin pumps, closed loop, measuring what your insulin is, your sugar is, and treating it. Now that you probably would say, well, an obvious cause there is bias, and I think it's hard to, and in fact that would be my takeaway from that, until proven otherwise. So there's a lot you can imagine that the statistics are telling us from across the board that deprived groups and those with ethnicity, certain ethnicities, are doing poorly across the board in healthcare, as picked out through the National Audit Programme. Just hit the next slide, please. Okay, so there are solutions, and again, please listen to the podcast with Aoife talking about this. Aoife talks quite well in depth about these different programs. So this was the Inhibit program. So intervention in hospitals to improve behaviour. Now, I'm not going to go into that because firstly, it's not my world, but it was a very important program, and as you can see, integrating public health principles into the setting. Now, the interesting thing about this is when you go and look this up, it doesn't come out nationally anymore, and that's because it was ended. Luckily, it was taken up locally and is now carrying on in its local guise. So when you look it up now, you'll see what one group of ICB or the one area of England or Wales are doing about this. So it did hit a button locally about treatment, and I think that's a theme that is now coming out in this. We have the idea we've got national problems and we've got national initiatives, but they're so slow to take a hold. And actually, a new approach, a different approach, might well be to start, well, why can't we do something locally? And I think that is going to be a much more successful approach in trying to get in under the skin of some of these problems. If you hit the next slide, please. This is PERI-PREM, which is perinatal excellence, reducing injury and premature births. And you can see the aim of reducing brain injury and death by at least half. That this is a national. You'll get this again, although it is more focused locally as well, and rightly so. It sounds like that this whole approach to moving things into a local sphere with local involvement. And not just, by the way, hospitals across the board, the whole system's starting to respond to the fact that we know that things are not being done well for the deprived and ethnic communities. The next slide, thanks. Okay, I just wanted to come in on this slide. Obviously, Core 20+5 has been a really important initiative, and indeed dealing not just with ethnic groups, but the other groups, the those that kind of miss out, so to speak, and probably never get coded. So the thing that has come through to me is about data. And this actually is similar to what we see in the kind of data for assurance versus data for quality improvement. And that kind of expression, is the data good enough? And we do dice it down, don't we? Data can be good enough for quality improvement. I think that's where we are now coming into with our approach in healthcare to ethnicity and deprivation. I think we need better coding. We need much better information. We need the information will start moving into algorithms. We'll be able to start to drill down into cardiovascular disease, prostatic cancer, these kind of things. But the other kind of social things, I think we could say we have a lot of data now, and that data is good enough for us to get ahead and make some differences. And as in the second bullet down, that the national data is definitely there, and we'll get better as we move on. But we're not going to sit and wait for 2 or 3 years, think, well, that data is that's not very accurate or whatever. We'll wait, because we've just seen between 2000 and 13 and 2022, not really much changing. We're not planning. We cannot, as a society, plan the next decade. We're sitting on our hands thinking, well, when the data's better, we'll do something about it. So I think we need these local focused approaches, and those 2 examples that Aoife has given in that podcast are exactly the kind of examples that we should push ahead with on a much wider basis to try and tackle these inequalities that are so stark. Thanks very much. If you just hit the last slide. So I think that's giving you an overview of where I think we are, where it's not a great place, but I think it's a place where we have kind of focused in now on, okay, we need to start doing stuff. We have good enough information, and across the board we start working on that. And at the same time, the national initiatives need to be progressing on. I think that message, I hope that's a message I've been given across. Would you like to, we could have some time now for questions if anybody's anything would like to ask us. Bren. Hi, Bren, are you there?
I've just allowed your mic if you'd like to unmute.
Yeah, Bren's still muted. Well, the whole fire, Bren, was trying to get you unmuted there.
Yeah, should we? Ruth's posted a question in the Q&A, Danny, which we could answer maybe first, and that's, is there influence that HQIP can have over national programmes to reduce inequalities, e.g. Daphne, educational programme for patients that's only available in English, and breast screening programme invites in English?
Yeah, I see HQIP in this as an influencer. Like, what do? We measure outcomes for patients, and when we're looking at outcomes, we then bring out recommendations. We're looking at variation in care and the like. And what are we doing? We're seeing a lot of variation in care. So what our role in this is to bring that variation in care to those who can make a difference. And that would be NHS England, and we're not going to go into any politics. NHS England and the NHS in general, no matter who's running it, and they are fully aware that Core 20+5 is an NHS England initiative. So our role in this is to just keep bringing it to the fore from the audits. And as I said, our role also is, as the audits retender, and bearing in mind we've got something like 48 audits covering virtually all areas of healthcare, well, very wide areas of healthcare, we will be getting better information. But I just want to get that message across, that we don't want to wait for better healthcare information coming out in 2 years' time. I believe that at the minute today, we have pretty good information showing us that there's a problem. And I think we need to be pushing it. So us, the us, is bringing that information to the powers that be, those that can make the decisions, and that may be local, maybe central, maybe whatever. And that's what our job is, and we are doing that. Thanks. Yeah. Bren is still muted. No, any other questions there, Vicky?
Ruth's actually got a hand up, so I wonder if it's...
Far away, Ruth. Muted as well.
Yeah, struggling to take yourself off mute as well, is it? We have unmuted centrally, but...
I'm not sure what's happening because the mics are enabled, so I'm not sure why. Is it greyed out that you can't unmute yourself? Ah, okay.
Yeah.
That's interesting, isn't it? Perhaps pop it into the Q&A again. Bren's decided to leave and rejoin.
Oh, right. Yeah. So,
just going to scroll up and down quickly, Danny, to see.
Sure.
Yeah, it looks like everybody's mutes might be greyed out. So yeah, so we'd encourage people to post in the Q&A. Obviously, if you post and we don't get a chance to mention everything, we will try and include some responses when we publish the slides and the recording. I mean, Bren has put some comments around, could we perhaps start calling it health inequities rather than health inequalities? And also that, you know, we need to have that focus on Gypsy, Roma and traveller communities.
Yes. Thank you for that, Bren. I know you may not be able to talk, Bren. Hope you can hear me. Bren, you've done great work in the Gypsy Roma community and indeed many other areas. So thanks for all that work you're doing. And thank you for reminding me. I meant to actually pull that out when I was looking at CAAW25, but I was trying to get all the other outputs out, Bren, so please forgive me for that.
Brilliant. So I think I can see Ruth typing, so we can be responding to any questions in the Q&A as well. So I think we'll move on to the next slide then.
Sure. Okay, thanks very much, everybody. And you'll have got my email. Please just come back to me on my email and other colleagues' emails. So we're going to go into the Clinical Audit Hero Winners Awards. And firstly, thank you to everybody who put in an application. I can't work out the number of applications in this particular theme, but we had 135 applications. That's pretty spectacular. So thank you for everybody who's done some work in this. That just highlights the amount of phenomenal work that you are doing, and thanks again for that. So we essentially have a runner-up and a winner. So the first to announce is the runner-up, and the runner-up for this is the person doing is Charlotte Githouse, and she is from Children and Families Division of the Hampshire and Isle of Wight Healthcare NHS Foundation Trust. So Charlotte, thank you so much for that, and you can see how you were very well thought of by the judges. I'll just read out a few points that the judges did make. And congratulations again. So essentially the project was focusing on support for families transitioning to parenthood. It's a very, very interesting niche area, that, but one that we all go through. And so it was a 9-month pilot addressing inequalities and focusing on non-birthing parents and carers, and particularly BME communities, and those with English, whose English was a second language. And essentially, the changes made were based upon input from the service users, and there was a clear evidence in the project of improved outcomes. For instance, reduction in depression, increase in warmth and empathy, but in the groups. So thanks again, Charlotte, and well done for being a runner-up. If we go on to the next slide, please, who is the winner? And the winner is the Nicotine Replacement Therapy Quality Improvement Team from Respiratory Department, St. Richard's Hospital, Chichester. So congratulations, you've won this in the teeth of opposition, and I'm pretty sure there's a colleague from the St. Richard's Hospital with us who's going to give a presentation on this. So congratulations. Could I introduce you? The next slide, please. And keep going. Right, David, I think you're there, aren't you?
Wonderful. Yes, if you can hear me, I'm going to try and take
I can.
So I'm delighted to accept the award on behalf of our team. This project was a huge amount of hard work over many months, and of course the work's ongoing as well. So I'd like to thank the organisers for inviting me to share some more details about our project. Next slide, please. So My name is David Lodge. I'm a respiratory consultant in Chichester. Our hospital is a medium-sized district general hospital on the south coast of England. We have just over 400 beds. If you've never visited, Chichester is a lovely place to live and to work. And I'm told the sailing is good as well. I've had the privilege of leading a team of doctors and nurses, pharmacists and other healthcare professionals in this project over the last 12 months. Next slide, please. I've got no disclosures. Next slide. So, spoiler alert, smoking is bad for your health. Although we haven't always pushed that message. Astonishingly, smoking kills nearly 1 in every 2 people who smoke, and it's the single biggest cause of preventable morbidity and mortality in the UK. Next slide, please. Currently, there are around 6 million adult smokers in the UK. This is data from a monthly household survey in England. The number of smokers has halved in the last 15 years, but still about 1 in 10 adults in the UK smoke every day. Next slide. We also know that smoking prevalence is disproportionately higher amongst individuals from lower socioeconomic classes. This is data from a different monthly survey of adults in England, and you can see that people in social classes C2, D and E are more likely to smoke. Spending on tobacco consumes a relatively high proportion of household income, so tobacco addiction can lock people into poverty. And if you have something this damaging that disproportionately affects one cohort in society, it should come as no surprise that smoking is the single largest driver of health inequalities in the UK. Now, the nicotine contained in cigarettes makes smoking intensely addictive, and once you've started, it's very difficult to stop. Next slide, please. But many smokers do want to stop smoking, and last year more than 1/3 of smokers in England tried to quit, and of those about 1/3 did manage to quit. And it's never too late to quit smoking, but we need to help people to stop smoking at the earliest opportunity. We also know that the most effective way to quit smoking is with a combination of nicotine replacement and psychological support from a stop smoking specialist. Next slide. Now, being admitted to hospital is a significant life event. Just think about a time when you've been in hospital or one of your relatives has. You probably remember some elements of the experience quite vividly. So being admitted to hospital, whether it's for a smoking related illness or not, offers a vital opportunity for someone who is tobacco dependent to quit smoking. Quitting smoking also means you're more likely to recover faster from an acute illness. Next slide. My motivation for this project was also founded in arriving at work every morning and having to walk past people smoking outside the front doors of the hospital dressed in their patient gowns, despite officially being a non-smoking site. And I'm sure some of you in the audience can share that experience. But anecdotally, we also knew that our patients weren't getting nicotine replacement. And nationally, only about 5% of smokers in hospital are prescribed nicotine replacement. And how can I ask someone to stop smoking if we as a hospital can't provide the resources to help them to quit? Next slide. So that's the background. The aim of our QI project was to increase the number of inpatients in our hospital who are current smokers receiving nicotine replacement therapy. Now, to illustrate our project, let's consider things from the perspective of a patient. Next slide. This is Ken. Ken is 70 and has smoked since he was 12. He gets admitted to hospital one evening with a cough and is diagnosed with pneumonia. He's not too poorly, but he needs to stay in for a few days for antibiotics and oxygen. Within a few hours of coming to the emergency department, he started to crave a cigarette. He makes it through to the following lunchtime when he decides to take off his oxygen and step outside the hospital to smoke. He gets a few irritated glances from members of staff, but he's feeling much better. He continues to pop outside every few hours to smoke, and after 2 days, he's well enough to go home. This is a missed opportunity. Next slide. So let's rewind and consider how it could be different. Ken is admitted late one evening. Next slide. The nurse who takes his observations asks him about his smoking. Next slide. And she gives him some brief advice about quitting, which Ken thinks about overnight. Next slide. The nurse records his smoking status, which is logged on his electronic hospital record. Next slide. The doctor who clerks him in overnight notices this and offers Ken a nicotine patch and an inhalator. Next slide, which he reluctantly accepts. In the morning, Ken doesn't crave a cigarette for the first time in years. Next slide. He meets Katie, a tobacco dependency advisor, who talks to him some more about quitting smoking and offers to refer him to his local pharmacy for support. Ken agrees to take this opportunity to try quitting smoking. Now, in front of you here is effectively a process map, and it formed the basis of our QI project. Patients should be offered nicotine replacement within 2 hours of a hospital admission. So at each stage of a patient's admission, we worked out the steps that needed to take place to meaningfully document someone's smoking status and ensure they receive nicotine replacement as soon as possible. Next slide. So we started by looking at recording a patient's smoking status. All patients should be asked about smoking as part of the nursing documentation on admission, but we were only doing this mandatory assessment for about 40% of admissions. Next slide. So we started doing some teaching for nurses and healthcare assistants who were the ones doing these assessments, and it made no difference. The line is stubbornly flat. So we spoke to the nurses on our medical wards, and we discovered that the assessment doesn't flag as being overdue until about 24 hours into the admission, and you can choose to skip it. Next slide. So we've made the assessment mandatory within 6 hours and removed the option to skip it. Next slide. And we've also added a script for nurses to read, offering very brief advice to patients about quitting smoking. And there's no point in doing the assessment unless you then do something with that information. So we're now working to make this assessment more visible on a patient's electronic patient record when they're admitted. Next slide, please. So we then looked at nicotine replacement. Now, if you ask a resident doctor what nicotine replacement therapy to prescribe, you'll probably get a blank look and then a mumbled response about asking the patient how much they smoke. And that's exactly what we found in our baseline qualitative interviews. And when you ask a resident doctor how confident they were in prescribing nicotine replacement, their self-reported confidence was fairly low. Next slide, please. And it's unsurprising when you look at the official prescribing information from the trust at the top there, which is very detailed, but not very easy to follow, or the electronic prescribing system at the bottom of your screen, which doesn't really give you any guidance at all. Next slide, please. So to make things easier, we created a protocol on our electronic prescribing system, which gives just 2 options: a high-strength patch, either for 16 hours a day or 24 hours a day if the patient wakes up wanting a cigarette, and some fast-acting nicotine, either a mouth spray or an inhalator, which is just a dry powder device that mimics the action of smoking. And this is based on guidance from the British Thoracic Society. And we chose high-strength patches because the greatest risk of relapsing back to smoking is prescribing an insufficient dose of nicotine. Now, how do you encourage resident doctors to change their prescribing behaviour? Well, you can put some posters round or run some teaching sessions, but that effect is usually short-lived. Really, you need to give them some sort of incentive. So to promote uptake of this new protocol, we ran a competition. The doctor who prescribed the most nicotine in a month won a box of biscuits. Next slide, please. We only ran the competition for 2 months, but it was enough to start people prescribing the protocol. Next slide. And when I stopped running the competition, doctors continued to prescribe the nicotine replacement therapy protocol. I'm not sure if they're still expecting me to give them more biscuits. And was it the biscuits that made the difference? Well, we share a prescribing system with another hospital in the same trust. Next slide, please. The protocol was introduced on both sites at the same time, but our data show that the protocol just isn't being prescribed at the other hospital. So by the end of the project, the doctors in our hospital had prescribed the protocol over 10 times more, long after the biscuits had been eaten. In other words, we've successfully changed the culture of prescribing nicotine replacement in our hospital. Next slide, please. Now, of course, it's no good prescribing nicotine in the middle of the night if you can't give it to the patient straight away. So we worked with our pharmacists to stock this limited range of products on every adult ward in the hospital, so that patients can be given nicotine replacement as soon as it's prescribed. And the products come in packs for patients to take home with them at the end of their admission. Next slide, please. We then received some funding for a tobacco dependency advisor, who is automatically notified about all patients recorded as being tobacco dependent and supports them to start a quit attempt. We've now got 2 advisors. This is Katie and Asara, who between them provide 5-day-a-week cover in our hospital, and feedback from patients has been extremely positive. Next slide, please. Throughout the project, we used patient co-design to ensure that our changes would be successful. We received feedback from smokers about discussing their tobacco dependency, about which nicotine replacement products would be most helpful, and for some advice on creating patient information leaflets and how best to refer them to community services. Now, after all that, did we make a difference? Next slide, please. So yes, by the formal end of our project in November, we'd started to see a significant increase in the delivery of nicotine replacement therapy to inpatients. Next slide, please. And in particular, we've seen a significant increase in the delivery of high-dose nicotine patches, which we know are more likely to be effective at preventing withdrawal. And our project is now being used as a model for the Trust's smoke-free policy and has influenced the appointment of tobacco dependency advisors to all hospital sites in the Trust. Next slide, please. So we come back to our process map, and you can see that at each stage of a patient's journey into the hospital, we've influenced change to make the most of an opportunity of an inpatient admission in helping someone to start their journey towards being smoke-free. Next slide, please. So what do I want you to take away from this talk? Well, firstly, remember that smoking is the single largest driver of health inequalities in the UK, but that 1/3 of smokers will try to quit this year. And being admitted to hospital is an opportunity to help people who are tobacco dependent to quit. Next slide. More broadly, if you're looking at any project focusing on a pathway, it's helpful to generate a process map and truly understand every element. This often means having informal conversations with those involved. Next slide. And then gathering and presenting data in a way that helps you to understand where the problems lie so you can start to make meaningful changes. Next slide. If you're doing a project involving resident doctors or any other healthcare professional for that matter, I highly recommend biscuits as an excellent motivator, and that can change behaviour. And next slide, please. Projects are always better in teams. When we were looking at admission assessments, my specialist nurses were able to have far more fruitful conversations with their nursing colleagues than I could get. And when we were looking at prescribing data and stock levels, it was the pharmacists who explained what was really going on. But hopefully some of what I've talked about has inspired you to realise that healthcare provides unique opportunities to make a genuine difference to people's lives. And the success of this project wasn't just about frontline staff putting nicotine patches on patients. It was about people behind the scenes gathering data and presenting it in ways that helped us to understand what was really going on, how we could make changes that would have a real impact, and being able to demonstrate that the changes we were making were effective. Next slide. And I'd like to acknowledge the team behind this project. We worked with colleagues from the medical wards, our specialist nurses, a fantastic team from pharmacy, and our growing team of colleagues working with tobacco dependency. Next slide, please. Now, throughout our project, we've followed guidance from the British Thoracic Society. And if this is something you're interested in replicating, I'd encourage you to look at the BTS tobacco dependency work led by Matt Everson up in Manchester. The link is there on your screen. And with that, I'd like to thank you for listening, and I'm happy to take any questions.
Oh, that's brilliant. Thank you, David. Very, very inspiring. And I think I'd challenge everybody to certainly scan that QR code and get in contact with BTS to find out a little bit more and to share your project with their health inequalities teams back in their own organisations. Lots to learn. Brilliant. Definitely got some Q&As in the chat, and we've got a hand up as well. So if Louise could unmute again, it looks like you might be unmuted, Bren.
Yeah, so I've unmuted. So first and foremost, can I take the opportunity to thank yourself and rightly so the team around that, really, that obviously as a collective completely got it, because if you haven't got a team that's got it, or we got one that hasn't got it, might want to. So there's something about how you form the team and kept the team on the focus and direction. So that's about leadership, which you didn't mention, but it's so important. The other point I just put in the chat, in the question and answer bit, really, is I noted that you said it was 5 days a week for the tobacco advisors. And I'm just wondering whether or not, again, resources aren't always there and as much as we'd like. But I'm just wondering if that extension to 7, so it's a complete 7-day service to capture people that you might not capture for those 2 days. Any thoughts on that? And again, congratulations.
Oh, thank you very much. 7-day-a-week services are something, of course, we all aspire to, and the funding just isn't there, not just for tobacco dependency, really, across the hospital, but all patients who are admitted and have their smoking status recorded, all of those patients are now automatically flagged to our tobacco dependency advisors. So if someone comes in on a Sunday, for example, they'll be picked up on a Monday by our tobacco dependency advisors if they're still in hospital. So yeah, hopefully we won't miss too many people that way.
Thank you. And the reason why my hand's still raised is I can't get it down on this computer. So that's me. I'm just a bug in the system, and so if you see it up, it's not another hand. Thank you.
Oh, lovely. Thanks, Brent. And I'm just scrolling back down because we've not seen any more hands at the moment, but I know Sarah's posted a question here. Thanks, David. Great project. Do you have any idea of the successes you had in prescribing an NRT to inpatients resulted in longer term smoking cessation?
It's a really good question, isn't it? I don't think that the prescribing in and of itself is necessarily the be all and end all. It's a really important start. I think there's a lot more focus now on tobacco dependency advisors picking up these patients, having conversations with them and helping them to start their journey towards being smoke free. And of course, that involves referral onto community services as well. And we're starting to have conversations with our local providers about what they're able to offer across the patch. So now I'm afraid I don't have at the moment sort of longer term data about smoking quit rates. But that's something we're looking to record. So hopefully there'll be another demonstration of success of this project and also help to identify other areas in which we can continue to improve.
Lovely. Thank you, David. So I'm not seeing any more questions in relation to your project. You've got some lovely comments in the Q&A actually, David, if you scroll up and down. There are a couple of other questions in here that might be more for Danny and HQIP. Beatrice has put in what mitigations have been taken in light of the fact that the ethnicity assigned to a patient in a data set may be incorrect. Inconsistencies are apparent when we compare the ethnicity recorded for people in HES data sets with the one recorded for them in the 2021 census.
I'll try. I can't really answer that, but I'll give my thoughts. Like obviously, this came out in the survey that Alison, our colleague, did over a year ago, which obviously picked up that, and I suppose that it was picked up because the various patients where this was flagged up were presenting more than once and were given more than one ethnicity code. I'm not sure what we can do about it. All I know is that when you go to coding in primary care, it's much more secure, and there are obviously many reasons for that, because you're generally in a stable place, not moving around. So other than saying that the sooner we start merging primary and secondary care data sets, the better that this coding will get, and secondly, when we start seriously moving into the analog to digital, that not just coding but many other things are going to have to be much more sharp than we have now, and much more automated. And I'm not saying automation will definitely get rid of this problem. In fact, probably won't. But essentially, the training also to those who are working to put in codes and the like, who are generally very time-strapped and the like, that they have to also be helped to make sure that how important it is to get the codes right. Otherwise, we'll be left with a relatively poor information. But bearing in mind that the main theme of where I've come from to is that actually we have a lot of very good information to tell us, show us where to go and what to do. It'd be great to have much more secure information, and that more secure information feeding into the analysts who can start looking at some of the root causes of this, the non-social root causes, more medical root causes. Nevertheless, I think we've got enough to be getting on with at the minute. Thanks. And any others there, Vicky?
There is. This one might be back to David again. Winifred's just posted, great project, very well done. How long was your measurement for? And is there any recommendations for a reasonable time frame to measure for improvement for your experience with this project?
Great question. I think with all these things, it's never sort of a hard and fast finish point. So it's all about continuous improvement and continuous measurement. So officially our project ended in about November. I continued to monitor data, prescribing data up to about March, and that change in prescribing behaviour was sustained. But I think if you're looking to do a sort of formal quality improvement project, you're looking at data points and SPC charts and the like. So it's more about the number of data points that you have rather than necessarily a time period. But as we're continuing to measure that data to make sure that your change has been a sustained improvement. And also using that to identify areas where you can make further changes, perhaps. So yes, there isn't a hard and fast answer to that question. But yes, if you're interested in QI, look into SPC charts and data points.
Lovely, thank you. And I think we've got enough time for this other question here. So Rachel's just posted, great project, so important. Can I ask, how did you secure the resource, med cessation support workers and teams? Was it a business case to trust or did ICB support?
So the majority of what we did was cost neutral. Essentially, it was what we should have been doing all along. And some of it we were doing, but not very well. So things like recording somebody's smoking status on admission, well, we should be doing that anyway. So it was about trying to make sure that was a meaningful process. A little bit of that with the IT changes, that's outside our control, but it's part of a planned upgrade. So it took a few months to wait for it to happen, but it did happen eventually. Similarly with prescribing and stock levels, that should be happening anyway. So again, there was no particular cost implication. The cost comes in when we start talking about tobacco dependency advisors, and that was a bit of a battle at the start. We were given some money for COPD work and we rebadged it as COPD prevention. You know, by the time you've been diagnosed with COPD, you have substantial lung damage. So we used that money, we thought, more effectively to boost our resources where we thought we were letting people down with smoking. And that's where the initial money came through for tobacco dependency advisors. So that was health inequality allocation funding. And then we've managed to roll TDAs out across the trust, and that's been through service development funding, investing in frontline services which tackle tobacco dependency. So I think the work we've had has raised the profile a little bit of tobacco dependency, and I think people are starting to take notes and to put resources into that across inpatients in our trust.
Lovely, thank you. I'm going to ask for one last question out of the Q&A here, because I just think it's really important, and I will tailor what I say with the wrap up, just so we've got a little bit of time here. But Laura from Sheffield's just posted a question in regards to a project she's doing, but I thought actually it's really pertinent. She's just asking if we're aware of any national programs of work that are actually looking at geographical access to specialised services from the point of view of reducing those inequalities, because obviously we see that people do have to travel quite far sometimes to access those specialised services. So I don't know if Danny or HQIP are aware of any work along those lines.
I'm just trying to think. There's nothing springing to mind. I'm sure there are national initiatives going on in specialist areas, but there's nothing. I'm trying to think of the audits flagged up anything that would be important. I'm leaving out the neonatal maternity stuff because there's a huge amount going on there on a national front. Just at this minute in time, there's nothing in my head. But like, for instance, if you take that thing, prostate cancer and Afro-Caribbean, you would think there'd be something going on there, and that there may be something that the cancer team in NHS England are working on. I would hope so. There are other subtle differences in other cancers as well that ethnicity will have an important role. So I'm sorry, I haven't anything. If you leave that question with me, I'll maybe think on that one.
And we've got some good contacts from, obviously Hester was with us on Monday, and we've got a contact obviously on our slides. She's done a lot of work around healthcare inequalities as well, and Aoife Malloy as well. So there are some contacts that you could potentially pose that question to. But I thought it was actually quite relevant because we do have patients that do have to travel quite far. Okay, thank you. In the interest of time, then we're going to move you on because we've got an evaluation we'd like you to scan the QR code for. Thank you, Danny and David. That was brilliant. Lovely. So if you scan the QR code, we'll just screen share a few of you because we're going to ask you for some takeaway pointers again from the session today that obviously we'll use for future events. And obviously it's lovely to see it shared with our attendees and our speakers that have shared their information with you today. So please do scan that QR code and we'll get some takeaway points coming up. Feedback starting to come in. Brilliant. You can type as many times as you like. Lots of comments to come in. We do use them, as you know, we shared last year's takeaways with you earlier today in the session as well. And aware that it's asking you a few questions before you reach the takeaways. We've got a further slide coming up in a minute that's going to challenge you with some takeaways, and I suppose I could touch on that shortly whilst you're all typing in terms of going back to that adding value and that impact that we started off talking about at the beginning of the session, really, and 5 questions really that potentially will get you to ask as you're supporting projects or starting projects locally in your organisations across your systems around actually when you're thinking about what you're going to look to measure and improve on, how's it going to add value to our health outcomes and actually the impact it's going to have, and also how you're going to involve the local community in helping to shape what we measure, and also in terms of helping to drive those improvements to address those health inequities, as I'm going to start changing how I'm going to talk about it, Bren, based on your comment, and then what metrics we might use to evidence that. Obviously slide 7 and 8 in the pack was guiding you towards some metrics that you might use to show that impact. So we're starting to see your comments coming through now, which is really good. So yeah, invigorating. Yeah, I really do urge you to share David and his team's projects really with your own teams as well locally to see that you can replicate it. Brilliant, look at this. I think you've enthused our attendees, David, with your winning project. Yeah, you're right. There's a comment there about the work that still needs doing. We've still got a long way to go, haven't we? But it's just about us collaboratively committing to that and trying to use what we've got slightly differently so that we are starting to make those improvements and reduce those gaps in equity and access. Yeah, brilliant. So this evaluation is going to stay open so that for, I think it's the next week or 2, isn't it, Louise? So that if you've not had a chance to fully fill it in, or we've had colleagues that have had to leave the call early, you've got that opportunity to still add to it before we'll then publish the outcomes, your key takeaway points with the slide packs and the recordings for everyone to access after today. Brilliant. So I'm going to ask you to take that down, Louise, and just move the screen on because we've got some more events to highlight to you that's happening this week as well, including the Lunch and Learns tomorrow and Friday. Tomorrow on Influencing Change and Friday on efficiencies. And I know that very shortly, in about a minute's time, and I'll just get you to move that slide on, Louise, because I've touched on what we're challenging you with. And if we move on again, in a minute's time, I think we've got the CVD Prevent event that's about to start that HQIP are running as well. So obviously for those that are registered there, you'll be wanting to leave to join it. But it was just to highlight here tomorrow's Lunch and Learn with Sam Riley, NHS England's Director of Making Data Count. And we've got Claire Fountain from HQIP joining us well. And then on Friday, we've got Dr. Teresa Barnes from the RCP that's going to talk to us about some work that they're doing that's going to help obviously to drive those improvements across the system for us all. And you can see here on the screen, lots of resources, lots of blogs, lots of case studies, and there's another live webinar tomorrow as well around data-driven improvements in maternity care that you can access as well. So I'll just get you to move to the next slide then, Louise. And I think it's just that opportunity really now to thank everybody for attending today. Thank you to Danny for joining us as our key speaker, David for sharing his winning project. Just thank everybody that actually submitted their projects to the Clinical Audit Hero Awards, because actually it was hard to judge between them all. The calibre was a lot higher. And thank you to obviously to HQIP and NQICAN as well. So we're going to leave you there for today and hopefully see you at further events through the week. Have a lovely afternoon and enjoy this next event that's being run by CV Prevent and HQIP. Thank you very much.
Cheers. Bye now. Bye, everybody.
Brilliant. Thanks, everyone.
Thank you.
Okay, so it's 12:30. So